క్రాంతి ఆ ల్యాప్టాప్ లో మ్యూట్ చేసావా వాల్యూమ్? ఐ థింక్ యూ లాగ్డ్ ఇన్ ఫ్రమ్ బోత్ ఫ్రమ్ ల్యాప్టాప్ అండ్ మొబైల్ కదా?
దూరం పెట్టు.
ల్యాప్టాప్ ఆడియో మ్యూట్ చేసేయండి, సరిపోతుంది.
ఇప్పుడు లేదు కదా సార్?
బట్ స్టిల్ డిస్టర్బెన్స్ ఉంది. యాక్చువల్ గా ఫోన్ నుంచి మీరు మాట్లాడేటైతే ల్యాప్టాప్ ఆడియో మ్యూట్ చేసేయండి.
దీంట్లో మ్యూట్ చేసేది. Am I audible, sir?
Yeah, audible, but resound వస్తుంది still.
ఫోన్ లో ఆపేసి డైరెక్ట్ గా ల్యాప్టాప్ నుంచి ప్రింట్ చేయి.
లేదంటే యాక్చువల్ గా అందులో మ్యూట్ చేసినా సరిపోతుంది, ల్యాప్టాప్ నుంచి ఆడియో రాదు కదా.
Am I audible, sir? No?
Yeah, now better. Yeah, carry on.
Sir, shall I start?
Start.
Yes. Good morning, one and all. Today my topic of discussion is COPD and its anesthetic implications. Coming to the definition of COPD, COPD is a group of chronic respiratory disorders that lead to progressive tissue degeneration and obstruction in the airways and lung that is not fully reversible. They include chronic bronchitis, emphysema, and peripheral airway disease. According to American Thoracic Society, COPD is defined as disorder characterized by abnormal test of expiratory flow, which is structural or functional, that do not change markedly over periods of several months of obstruction. Risk factors of chronic obstructive pulmonary disease are cigarette smoking, occupational exposure to dust, chemicals, that is gold mining, textile industry, indoor or outdoor pollution, recurrent childhood respiratory infections, and low birth weight. Coming to pathogenesis of COPD, they include chronic bronchitis and emphysema. As due to smoking or occupational exposure like textile industry, there is inflammation and squamous metaplasia, and there is increased red blood cells, which leads to mucus hypersecretion and ciliary dysfunction. And due to smoking, there is noxious stimuli, and there is increased oxidative stress and inflammatory mediators. These chemoattractants proteolytic enzymes, they cause fibrosis and thickening of the bronchiolar walls, thereby causing irreversible narrowing of smaller airways, leading to fixed airway obstruction, causing chronic bronchitis. In emphysema, if there is genetic alpha-1 antitrypsin deficiency, which is an antiprotease, there will be protease antiprotease imbalance, leading to increased neutrophil elastase and matrix metalloproteinases. These degrade elastin by proteolysis, causing destruction of alveolar walls and capillaries, leading to fibrosis and decreased diffusion capacity through the alveoli. There is dynamic inflammation, hyperinflation, finally causing emphysema. And there is remodeling of extracellular matrix, reduced elastin collagen synthesis, and alveolar epithelial damage. These are the chemoattractants which got alerted to the alveoli. They are interleukins 6, 8, 10, TNF alpha, leukotriene B4, proteolytic enzymes elastase 4, proteinase 3, and cathepsin G. CD8 lymphocytes induce apoptosis of the alveolar epithelial cells, and CD4 lymphocytes induce autoimmune response to the lung tissue. Pathophysiological changes we see are air trapping, causing dynamic hyperinflation, fixed airway narrowing, and increased airway resistance. ventilation perfusion mismatch in particular zone of the lung, chronic hypoxia leading to polycythemia vera, and finally causing pulmonary hypertension, changes in respiratory drive. Pulmonary arterial hypertension, there is ventilator perfusion mismatch causing chronic hypoxia leading to secondary polycythemia and pulmonary capillary remodeling, finally leading to pulmonary hypertension. Coming to chronic bronchitis, it is clinically defined condition with recurrent excessive mucus secretion into the bronchial tree, resulting in airway obstruction due to edema and bronchial inflammation. Patient there should be at least 3 months of cough in a year for at least 2 consecutive years. Sputum is thick and obstructs airway. Emphysema, it is anatomically defined condition characterized by abnormal permanent enlargement of air spaces distal to the terminal bronchioles, that is respiratory bronchioles and alveoli, accompanied by destruction of their walls and without any obvious fibrosis. There is lack of uniformity in airspace enlargement, resulting loss of alveolar surface areas. Depending upon the type of the airspace involved, there are 3 types of emphysema: pan-acinar, central-acinar, and paraseptal. These are the differences between chronic bronchitis and emphysema. In chronic bronchitis, patient complains of chronic productive cough and there is purulent sputum. Initially, there will be mild dyspnea, cyanosis due to hypoxemia. Patient will be obese and there we see crackles and wheezes. Emphysema, patients complains of excessive dyspnea compared to chronic bronchitis. There is minimal cough. There is pink skin and pursue lips breathing, that is there is increased work of breathing in these patients. Aspirin muscle use will be seen in emphysema like sternocleidomastoid, pectoralis major, scalene muscle. There will be cachexic, so the patient will be low weight. We see hyperinflation barrel chest in these patients. Complications of this include in chronic bronchitis, due to chronic hypoxia, there will be secondary polycythemia vera leading to hypoxemia. Pulmonary hypertension due to reactive vasoconstriction from hypoxemia. Vasoconstriction meaning hypoxic pulmonary vasoconstriction, which is a homeostatic mechanism that is intrinsic to pulmonary vasculature, unlike systemic vasculature. Intrapulmonary arterioles constrict in response to alveolar hypoxia, diverting blood to better oxygenated lung segments, thereby maintaining ventilation perfusion matching and systemic oxygen delivery. This is pulmonary hypoxic pulmonary vasoconstriction. Coming to complications in emphysema, there might be bullae, and if they rupture, it causes pneumothorax. And as I told, there is increased work of breathing, so there will be weight loss. Changes in respiratory drive. Reduced surface, there will be reduced surface of area, so there will be chronic hypercapnia and hypoxia in these patients. And chronic CO2 retention due to inadequate expiration, reduced sensitivity of brainstem chemoreceptors. Respiration is hypoxia driven. COPD severity classification by GOLD classification, which is Global Initiative of Chronic Obstructive Lung Diseases. There is stage 1, 2, 3, 4. Mild stage is FEV1 greater than equal to 80% predicted. FEV1 is forced respiratory volume in first second in expiration. It is greater than equal to 80% predicted. In obstructive airway diseases, FEV1 by forced vital capacity ratio is less than 70% or 0.7. In moderate severity, we see FEV1 between 50 to 80% predicted post bronchodilator. In severe COPD, there will be FEV1 is 30 to 50% predicted. In very severe COPD, FEV1 is less than 30% predicted. Anesthetic consideration COPD patients undergoing surgery. Patient factors we should see are advanced age, poor general condition, nutritional status, if there is any associated comorbidities or not, like hypertension, diabetes, obesity, or sleep apnea. Problems due to disease we face are while doing airway instrumentation, there might be exacerbation of bronchial inflammation. If there is any associated preoperative airway infections, and we will be seeing increased work of breathing and increased post-operative pulmonary complications might be assessed. Problems due to anesthesia are general anesthesia decrease lung volumes, promotes ventilatory perfusion mismatch. Functional residual capacity will be reduced during anesthesia, during general anesthesia. And the drugs we use blunt ventilator responses to hypoxia and carbon dioxide. There might be post-operative atelectasis and hypoxemia in moderate to severe COPD patients. Due to post-operative pain, it might limit coughing and lung expression, and there might be secondary infections. Problems may arise due to surgery if the duration is greater than 3 hours, and if the surgery is emergency, and the position kept during surgery also matters. Preoperative assessment. Coming to history, we should ask the patient about his smoking history, and we should calculate pack years and the type of cough, progression, any reason associated respiratory tract infections. Sputum, we should ask whether it is color, quantity, and frequency of sputum production. Dyspnea grading, we should assess. Exercise intolerance and cardiopulmonary reserve, we should assess, and we should ask his or her occupation and allergy history. This is a dyspnea scale, modified medical research council dyspnea scale. According to this, there are 5 grades. 0 grade is the patient complains if he gets breathless with strenuous exercise only. Grade 1, he gets breathless when hurrying on a level or walking up a straight hill. Level 2, grade 2 is he walks slower than people of same age on the level because of SOB, or he should stop for breath when walking on his own pace. Grade 3 is he stops for breath after walking for 100 meters or after a few minutes on the level. Grade 4 is he's too breathless to leave the house, or and he's even unable to dress or undress. We should ask personal history. Cigarette smoking is the single most important risk factor, and we should ask about his occupation and occupational history to toxic substances and allergens. There might be family history of some protein deficiency like alpha antitrypsin deficiency, which leads to emphysema, any history of pulmonary hypertension in their relatives, and pulmonary fibrosis. During inspection in physical examination, we should look for features of airway obstruction like hyperinflation of chest or barrel chest in patients with emphysema, any decreased sounds bilaterally, or respiratory bronchi is heard or not, it should be seen. How we know there is increased work of breathing? There will be tachypnea or tachycardia, use of accessory methods of respiration, as I told before, like sternocleidomastoid, scalene, trapezius, pectoralis major, and external intercostal methods. Intercostal indrawing will be seeing and tripod sitting posture of the patient. His or her body habitus, whether he's obese or malnourished, as I told, the difference between emphysema and chronic bronchitis. Any active infection we should assess. Investigations. Complete blood count. There might be secondary infection, and there will be increased WBC count, serum electrolytes, blood sugars, electrocardiogram, ABG, chest X-ray, preoperative pulmonary function test for optimization of pre-op lung function. These are the investigations we should be assessing. Chest X-ray, there will be overinflation leading to barrel chest, and the ribs will be straight, the heart will be elongated and thin, that is tubular heart. Bullae might be present in emphysema, which might rupture leading to pneumothorax picture. This vertical cardiac cell heart, as I told, there is increased transdiameter of chest, and there will be square chest. ECG due to chronic pulmonary hypertension, it will lead to right ventricular hypertrophy and right atrial dilatation. Right atrial dilatation can be seen as P pulmonale. There might be right axis deviation and R wave progression in inferior chest leads 2-3 AVF. Increased preoperative in ABG, increased preoperative PaCO2 is a prognostic marker, and it is a strong predictor of potential intraop respiratory failure and post-op ventilatory failure. PaCO2 might also be increased due to post-op pain, shivering, fever, or respiratory depressants. Come to how we assess preoperatively patients' cardiopulmonary reserve by bedside pulmonary function tests. These are the various tests we assess before surgery. They include Sabrasich breath holding time, which normally it is greater than 40 seconds in normal patients. If it is between 20 to 30, there is a moderate cardiopulmonary reserve, and it is less than 20, that is poor cardiopulmonary reserve. Second one is Sabrasich single breath count. It assesses the vital capacity of the patient. Normally, it is greater than 50. Greater than 50 counts. If it is less than 15, that is poor. The patient has poor vital capacity reserve. Snyder's third test is Snyder's match blowing test. Maximum breathing capacity of the patient can be assessed by this match blowing test. Normally, from 22 centimeter distance, if he is able to match blow, that means his maximum breathing capacity is greater than 150 liter per minute. Cough test. We should ask the patient to deeply inspire and cough at once. If the cough leads to persistent coughing, that means the patient has chronic bronchitis. Wheeze test. Wheeze test is nothing but we should ask the patient to maximum deeply inspire and expire for 5 to 6 times, and we should auscultate between the interscapular area whether we find any wheeze or not. Maximum laryngeal height less than 4 centimeter on inspiration. That is chronic bronchitis. That is from the from the upper border of the thyroid cartilage to the suprasternal notch. If it's less than 4 centimeter on inspiration, it is indicative of chronic bronchitis. These are the bedside pulmonary function tests we assess. Spirometry. Preoperative spirometry may be useful to assess the disease severity and adequacy of bronchodilator therapy. Standard spirometry indices include, as I told, a forced respiratory volume in first second, forced vital capacity, and their ratio and vital capacity. The primary criteria for airway obstruction is decreased FEV1 by FVC ratio that is less than or equal to 70%, while in restrictive disease it's greater than 70%. Restrictive lung disease, there will be proportional decrease in all lung volumes. Thus, vital capacity, forced vital capacity, and FEV1 all are reduced. But as I told, FEV1 by FVC ratio remains normal or greater than 70%. These are the differences between obstructive and restrictive diseases. Total lung capacity will be normal or increased in obstructive airway disease due to inadequate expiration, while in restrictive lung disease it is reduced. And diffusion lung capacity of carbon monoxide is reduced in emphysema as there is degeneration of alveoli distal to the terminal bronchioles, while in chronic bronchitis and asthma only airways gets affected, so the VLCO will be normal. It is reduced in parenchymal disease and normal in chest wall neuromuscular disease. Preoperative preparation of the patient. Smoking cessation, airway dilatation, loosening and removal of secretions, eradication of secondary infections, and improve the strength of skeletal muscles by nutrition and deep breathing exercises. And if there is any altered imbalance, that should be corrected. What are the effects of smoking on various systems? Cardiac effects. It's a risk for development of cardiovascular disease in these patients. Carbon monoxide decreases oxygen delivery and increases myocardial work, and catecholamine release will be released and coronary vasoconstriction. It causes decreased exercise capacity. On respiratory system, it's a major risk factor for COPD. Decreased mucociliary clearance, causing hyperreactive airways and hypermucous secretion. It causes decreased pulmonary immune function. These are the various beneficial effects on the duration of smoking cessation. Within 12 to 24 hours, there will be fall in carbon monoxide and nicotine levels in the blood. In 2 to 3 hours, carbon monoxide, carboxyhemoglobin levels normalize and airway function improves. With 1 to 2 weeks of smoking cessation, there will be decreased photon production. 4 to 6 weeks, pulmonary function tests improve, and 6 to 8 weeks, there will be normalization of immune function. Ideally, we should stop before 2 to 3 months. Smoking should be stopped 2 to 3 months prior to surgery. There will be decreased overall post-operative morbidity. Dilatation of airways. Bronchodilators. It includes methylxanthines, which is a PD inhibitor, phosphodiesterase inhibitor. There will be increased calcium release from sarcoplasmic reticulum and adenosine receptor antagonism. This is a non-specific phosphodiesterase inhibitor. Commonly used is methylxanthine or oral theophylline we use. Anticholinergics are ipratropium bromide and tiotropium bromide. Ipratropium is short acting and tiotropium bromide is long acting. These anticholinergics are used combined with short acting beta agonists. Side effects of these anticholinergics as dry mouth, metallic taste. Beta agonists like salbutamol or terbutaline, short acting beta agonists. Long acting beta agonists are salmeterol or formoterol. The salmeterol dose is oral 2 to 4 mg per 4 mg or 100 to 200 mics per puff. Anesthetic techniques in COPD patients. Coming to regional anesthesia, it includes central neuraxial block and peripheral nerve blocks, which eliminates the need for airway manipulation and associated with 50% reduction in post-operative pulmonary complications. These factors make regional anesthesia a popular choice whenever feasible in COPD patients. Most of the pulmonary effects of neuraxial anesthesia are due to motor block of the intercostal and abdominal musculature. And benefits with regional anesthesia, there is no interference with airway, so it avoids bronchospasm. There is no danger of pneumothorax from nitrous oxide if there is bulle in emphysema patients. General anesthesia concerns. There will be airway instrumentation and secondary bronchospasm. Residual neuromuscular blockade, inhalational agent nitrous oxide if used as a toll, there will be rupture of bulle as air gets entered. Attenuation of hypoxipulmonary vasoconstriction in GA, so there will be ill effect. Respiratory depression with the drugs we are using, opioids and benzodiazepines. Opioids, they induce cough suppression, which is a component of balanced anesthesia. We commonly use fentanyl, and fentanyl should be given slowly. Otherwise, in large doses and in old age, it can cause chest rigidity, mimicking bronchospasm. We should differentiate both. Morphine and pethrin are known to cause histamine release. In coming to induction drugs, propofol. In cardiostable patients, propofol is an ideal agent because it causes better suppression of laryngeal reflexes during intubation. Ketamine, though it has bronchodilator property, it is unpredictable and dose related. It causes side effects like hypertension, tachycardia, which is not advisable. There is increased peripheral vascular resistance via indirect adrenergic stimulation with ketamine. Barbiturates, it is better to avoid thiopental as thiobarbitrates may cause histamine release. Oxybarbiturates like methylhistone can be used as less histamine release can be seen. Muscle relaxants. Non-depolarizing muscle relaxants which affect M2 receptors more than M3 receptors and has bronchoconstriction. So they should be avoided. Like examples are galamine, hypercuronia. Commonly used vicuronia, rocuronium affect muscarinic 3 receptors and can be safely used. Drugs like etracurium, mevacurium cause dose-dependent histamine release and increased bronchial tone, hence avoided. But cis-etracurium can be used as it causes less histamine release, like oxybarbital. Prior to intubation, to attenuate the airway response, we can give IV lignocaine 1 to 1.5 mg per kg, 90 seconds prior to laryngoscope. Opioid fentanyl 1 to 2 mg per kg, and adequate pain of anesthesia by giving all these drugs prior to intubation should be seen. Volatile anesthetics among the inhalational agents, halogen is the most potent bronchodilator. It suppresses airway reflexes and cause direct relaxation of airway smooth muscle due to beta adrenergic stimulation. Commonly used CO and isoflurane at higher max are equally good with halogen, but due to irritant smell, isoflurane may sometimes provoke bronchospasm in these patients. Ventilation strategy aim is maximum alveolar gas emptying and minimize dynamic hyperinflation. Dynamic hyperinflation or intrinsic PEEP is seen in these patients as in expiration, because inspiration is an active process and expiration is a passive process. Inspiration is not much affected, while expiration is a passive process. There is a trapping of air inside the alveoli, and with each breath the air gets trapped, and there is intrinsic PEEP or dynamic hyperinflation in these patients. Decrease minute ventilation, and we should provide adequate expiratory time to wash out the remaining air in the alveoli, and we should accept mild hypercapnia and acidemia. What are the intraoperative causes of increased peak inspiratory pressure? They can be bronchospasm, light anesthesia, coughing or bucking during surgery, obstruction in the respiratory port of the respiratory tube, or HME blocked or kinked tube, endobronchial intubation, and position of the surgery and pulmonary embolism. These cause increased peak inspiratory pressure. How do you manage intraoperative bronchospasm? By increasing inspiratory flow of oxygen to 100%, deepen the plane of anesthesia, as it's a commonest cause because of surgical stimulation under light anesthesia. So adequate measures should be taken to deepen the plane. Supplement the ketamine or propofol, endotracheal suctioning, and puffs with meter dose inhalers or nebulization with beta agonists. IV corticosteroids like hydrocortisone or methylprednisolone is indicated if there is severe bronchospasm. Extubation. These patients should be extubated in a deep plane of anesthesia, as it prevents bronchospasm during extubation, and the endotracheal and oral suction should be gentle, as it might provoke bronchospasm. Corticosteroid puffs through meter dose inhalers, supplemental oxygen after extubation. Some may require non-invasive ventilation immediately post-op. Post-operative care. Continue bronchodilators previously used, supplemental oxygen therapy, and lung expansion maneuvers, incentive spirometry, and deep breathing exercises. Continue chest physiotherapy and postural drainage. Post-operative pulmonary complications. We might see are bilateral basal atelectasis, continuous hypoxemia and increased PaCO2 in ABG, bronchopneumonia, or pleural effusion. Pneumothorax might also be seen if there is rupture of bullae. What are the predictors of post-operative pulmonary complications? Advanced age greater than 60 years, history of cigarette smoking, ASA grade 3 or 4, constitutive heart failure, pre-existing any pulmonary diseases or associated asthma. If the serum albumin levels are less than 3.5 gram per deciliter, these are the predictors of post-operative pulmonary complications. Risk reduction strategies of POPC. Preoperatively, we should ask for smoking cessation, bronchodilators, and control secondary infections. Post-operatively, lung volume expansion maneuvers and adequate analgesia should be given to the patient so that he does deep breathing exercises and there is no mucus remaining in his airways. As I told, lung expansion maneuvers, incentive spirometry, deep breathing exercises, adequate physiotherapy and postural drainage, intermittent positive pressure ventilation, and early ambulation of the patient. Thank you.
Hello.
Sir, good morning, sir.
Good morning. Good morning. Shekhar. Can I ask Shekhar? Yes, sir. Yes. Yes. Kanti, sorry, I joined little late for the class. And what is actually a deep plane of anesthesia you want to extubate your little? What is the main deep plane of anesthesia?
That means patient is not aggressively bucking on the tube.
So, not bucking on the tube is a deep anesthesia.
You should prevent bronchospasms for that.
No. What is it? You said deeper planes of anesthesia, right?
Yes, sir.
Can you tell me what are the planes of anesthesia?
Yes.
Well, administration. Madam. హలో నేను మాట్లాడలేదేంటి
Sir, lighter plane, deeper plane.
అనస్థిషియా స్టేజెస్ ఆఫ్ అనస్థిషియా చెప్పబ్బా అనస్థిస్ట్ క్రాంతి గుడిల్ స్టేజెస్ ఆఫ్ అనస్థిషియా చెప్పు
Yes, sir.
అండ్ ప్లేన్ స్టేజ్ 4 లో ప్లేన్
Induction, excitement or delirium, surgical anesthesia and overdose. Finally, respiratory arrest. 4 stages of Godels.
And there are 5 planes in stage 4, no?
Yes, sir.
When do you call deep anesthesia? What is the plane of deep anesthesia? ఇప్పుడు నువ్వు అసిస్ట్ చేసేది ఓటీలో బిస్ మానిటరింగ్ చేస్తున్నావా?
No, sir.
Sorry, నా natural section చేసేప్పుడు
Shall we move on to other question? Another question, sir?
పేషెంట్స్ కి సిఓపిడి ప్రీ ఆప్ అసెస్మెంట్ నేను మిస్ అయిపోయాను తెలుగా శేఖర్ బాబు. అందులో 6 టెస్ట్లు ఆస్మా వాళ్ళకి పనిచేస్తాయా? 6 మినిట్ వాక్ స్టెక్ లాంటివి ఏమైనా పనిచేస్తాయా?
అర్థం కాలేదు సార్.
ప్రీ ఆప్ మెడికేషన్ మామూలుగా ప్రీ ఆప్ పిఎస్సి అనస్థిషియా చెకప్ ఫిట్నెస్ చూస్తాం కదా.
ఎస్ సార్.
అలాగా మనకు మెడికేషన్స్ లో తీసుకున్న వాటిల్లో ఎంత అగ్రెసివ్ ఉంటామో అది తీసుకున్న, ఎందుకంటే మనం ఆల్రెడీ ఇంతవరకు వాడి ఆపేసి మళ్ళీ మధ్యలో వస్తే వెంటనే ఎంత టైం ఇస్తాం?
ఓకే.
ఎమర్జెన్సీకి ఎలక్ట్రిక్ మళ్ళీ మారుతుంది కదా.
ఎస్ సార్, ఎస్ సార్.
అది ఎలాగానే అంతే.
For emergency, we will give short-acting beta agonist, sir, and we will give inhaled short-acting beta agonists, and we will optimize as far as we can, and we will take up for surgery. For elective surgery, we will, if the patient is not having any exacerbations in the past 3 months, you can continue with the short-acting beta agonist therapy, and we can go with the surgery. And we can also add inhaled corticosteroids. And if the patient is having an exacerbation within 3 months before the surgery, then we have to optimize the patients by doing the PFTs again, and we have to assess the severity of the disease, and we have to wait at least, if it's an active surgery, we can wait up to 2 to 3 weeks, and after optimization, we can post the case. Any more questions?
Sir, good morning, sir.
Sir, good morning.
What is the optimum FiO2 that can be given for a COPD patient on ventilator? Next, how can you recognize auto PEEP on ventilator?
Good morning, sir. Auto PEEP can be recognized by in the expiratory wave, sir. There will be a gap between the baseline and the expiratory wave. It is intrinsic PEEP or auto PEEP.
Okay, next question.
Optimum FiO2 is 0.8 to 1, 80% to 100%.
No. If you give high FiO2 in a COPD patient,
No.
What
it should be around, it's around 35 to 50% only, sir. Not more than 50%.
Yes. What happens if you give high FiO2 in a COPD patient?
There is HPV will hypoxic pulmonary vasoconstriction might be lost.
No, it will take away the central respiratory drive.
Yes. Okay.
In COPD patient, usually we depend on carbon dioxide drive. But in COPD patients, they are accustomed to chronic high levels of COPD. So they depend on hypoxic drive for respiration. If you give more 100% oxygen, central stimulation will be lost.
Okay, sir. Thank you.
Hello. Can I ask, Dr.
No. Good morning.
Good morning. If in the history, on medical history or treatment history or in personal history, in the medical history, patient have inhalers and steroids. So how we are justifying the peri-op concentrations, anesthesia equipment? And the second one is a personal history. Patient on smoking, say smoker. So what is the smoking index?
Perioperatively, she's on short-acting beta agonist. That should be continued, madam. Pack years
What
are.
what are the complications you can see and peri-op concentration of steroids?
Steroids. Long-term steroid use. There might be steroid unresponsiveness, hyperglycemia. Osteoporosis.
Oral candidiasis, patient have muscle weakness, osteoporosis, and chances of infection.
Okay.
So if the patient is a major surgery,
Yes.
so what steroid you want to give? If minor surgery, how much dose you want to give?
If it's a minor surgery, 25 mg hydrocortisone during induction, and if it's a moderate surgery, 100 mg hydrocortisone during intubation and 100 mg TID for that day. And if it's severe case, 100 mg hydrocortisone during intubation and 100 mg TID for 2 to 3 days.
So major surgery, 100 mg TID dose you have to give.
Yes, ma'am.
What is smoking index? How it is useful?
Number of pack years.
Number of cigarettes into years. So if the number less than 100, it is a mild smoker. So 100 to 300, that you can think about the post-op complications. If more than 300 it comes, it is a major complication. Patient might be or maybe lung adenocarcinoma. You can think that one.
Okay, ma'am. Thank you.
And in the investigation, how it is useful HB and WBC and eosinophils and platelets and
If there is chronic hypoxia, there might be secondary polycythemia, and associated infections will be seeing neutrophilia or neutrophilia. If there is any associated allergy, eosinophilia will be seen in CBC.
okay, if polycythemia is there, patient has chances of DVT and thrombosis. So patient compulsory have to start anticoagulants.
Okay.
And now how can you differentiate chronic bronchitis and emphysema?
By generalized appearance, madam. His complaint when there is productive cough and the grade of dyspnea should assess.
And in the history of sputum, how can you differentiate the emphysema and the chronic bronchitis? About the sputum.
In chronic bronchitis, there will be product of thick sputum, madam. In emphysema, sputum production is less compared to chronic bronchitis.
In chronic bronchitis, Sputum is solid or scanty and less than 100 ml per day. In emphysema, sputum is a liquid type and more than 125 ml and maybe foul swelling or infection.
Okay.
And you showed about one slide, blue or pink blotter. That also very important in the exam.
Okay.
And what is the tripod position?
Madam?
Exactly, I don't know. What is the position patient have? Tripod, I think, is something. And patient cannot in a supine position. No, he always in a lie down, sitting position. What is the name of the position?
Reverse stand madam. Sitting tripod position, madam.
Yeah. Why? How is it useful that person?
Gravitational gravitational drainage of secretions.
No, is because he want to use the accessory muscles and extra thoracic muscles. That's
Okay.
why he has always sitting in position.
Okay, ma'am.
How it is useful in spirometry?
Pre-bronchodilator, post-bronchodilator, whether there is any improvement in FEV1 grading.
So because it is, you can know about the degree of damage, the reversal of the treatment, and stage of grading of the COPD. And you can know the volumes and capacities. What are the volumes you can see, and what are the capacities you can see?
Volumes we see are tidal volume, inspiratory reservoir and expiratory reservoir volume. Capacities are inspiratory capacity, vital capacity. FVC,
FRC also.
Yes, functional residual capacity.
Okay. During induction, which are the drugs you can use? Which drug is more bronchodilator?
Ketamine, madam. Induction drug ketamine has bronchodilator property.
Okay. What are the relaxant used in COPD patient?
Vecuronium, madam.
Any other?
Cisatracurium.
And a Rockrell. Okay.
Yes.
What is the inhalation agents?
Inhalational agent, madam. Halothane is ideal, madam, as it has good properties, bronchodilator property, suppress airway reflexes, but commonly we are using SIVO and ISO. Isoflurane can provoke bronchospasm due to its pungent smell. Sevoflurane can be used.
Sevoflurane is the best drug, and iso-antidesperone causes airway irritation. And what about halothane? Just now, Shrikant told about the halothane.
Yes,
I
ma'am.
mean, because chances of arrhythmias. That's why halothane is contraindicated.
Okay.
So, in the exam point of view, you can ask why can't halothane? Because it's arrhythmias.
Okay, ma'am.
And the treatment history, patient on beta 2 agonist and salbutamol and steroids. Salbutamol side effects.
Hyperglycemia, tachycardia, hypokalemia.
That is hypokalemia arrhythmias. Salbutamol, especially tachycardia and tremors.
Okay.
Hmm.
Thank
And
you.
last one, if patient have smoker, what are the changes occur in airway in the lung?
Airway remodeling, madam, and there will be fibrosis of alveolar walls with irreversible fixed airway obstruction will be seen. Fixed airway obstruction, narrowing of the smaller airways, mucus hypersecretion, hyperreactivity of the airways.
What about V by Q, ma'am?
What, madam?
V by Q.
Ventilation perfusion ratio decreases, madam. If there is localized hypoxic pulmonary vasoconstriction, it neutralizes.
What about carboxyhemoglobin?
Carboxyhemoglobin rises, madam.
Which side shifting to body seeker?
Left side, madam. Left side shift of bodies.
Stages of COPD according to FEV1 class.
Stages, madam. Stage 1 is FEV1 greater than 80%. Stage 2 is from 50 to 79%. Stage 3 is from 30 to 49%. Stage 4 is FEV1 less than 30%. Gold stage.
Thank you, Kranti. Thank you, Shekhar.
Thank you, ma'am.
What is the upper inflection point and lower inflection point in pressure volume curve?
Sir?
Pressure volume curve. Your aim of measuring PEP is closer towards which point? Upper inflection point or lower inflection point?
Lower, sir.
What are the maximum oxygen consumption normal? If it is less than 30 ml per kg per minute, it should not be taken. Normally 60 ml per kg per minute.
Okay.
You have put a patient of COPD with type 2 respiratory failure on NIV. And when do you want to repeat the ABG?
If his saturations are not improving and if there is persistent tachypnea, I will repeat, sir.
After how many hours, days?
Don't know, sir.
Any patient you put on NIV, you have to repeat the ABG after 2 hours. and see improve. If the improving the parameters are there, you can continue. If it's not improving or deteriorating, you have to intubate and put on ventilator.
Yes, sir.
What are the contraindications of NIV?
Any patient necessary
అదే మార్నింగ్ ఫస్ట్ కేసు
Depending upon ventilation perfusion matching, lung is divided into 3 zones by
Sir, not audible. Sir?
ventilation perfusion, V by
Yes,
Q.
Yes, sir.
Lung is divided into 3 zones, okay?
Yes, sir.
From apex to bottom.
Yes, sir.
Which is ideal zone? And what is the VQ by ratio in that zone?
There are 3 zones, sir. Ventilation and perfusion ratio is 0.6 in lower zone, 0.8 in middle zone, and 3.2 in upper zone, sir. Ideal zone is lower zone, sir.
No, middle zone, 0.8 is ideal.
Okay.
Thank you.
Thank you, sir.
Any more questions?
Thank you.
Kranti?
Sir.
Last question, what is GOLD?
Sir, GOLD, sir. Global Initiative for Obstructive Lung Diseases. Stage.
Okay. Okay. What are the GOLD classes?
Four classes, sir. Based on
sure?
last question అనకూడదు కదా.
Are you sure? There are 4 classes? Actually, initially there were 4 classes only, A, B, C, D.
Yes.
Now recently they got changed to A, B, and E. E for exacerbation.
Okay.
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 Okay. Recently the guidelines also changed to COPD. 2023 guidelines have come, and there are certain recommendations for particularly for stage B and E. Go through them. Okay. And when to use inhaled corticosteroids, when not to use inhaled corticosteroids, what is the level of evidence, and everything is there in the recent guidelines. Please go through that, because for the exam these guidelines are necessary for you. Okay. And one more thing, don't forget the basics. Okay. Basics must be strong. Okay. You shouldn't forget about good stages of anesthesia.
Okay.
Okay. Right. After 10 years we can forget, but you are still in the training program now. You cannot forget good stages. Okay.
ఏం సార్ 10 years తర్వాత మర్చిపోయినా పర్లేదా?
అలాగా సార్, వాడికి మర్చిపోయే ఛాన్స్ ఉంటుంది, బట్ హీఈస్ స్టిల్ ఇన్ ద ట్రైనింగ్ పీరియడ్ కదా సార్. దట్స్ వాట్. బికాస్ సడన్ గా మీరు స్టేజెస్ అనేది నాకు కూడా గుర్తు రాలేదు, అందుకని అంటున్నాను.
థ్యాంక్ యూ క్రాంతి.
థ్యాంక్ యూ.
Thank you, sir.
Thank you, Kranti. Thank you, Shekhar. Thank you to all.
Thank you, madam.